Hi, good evening, everybody. Welcome to our another session of our nurses webinar, followed by the doctors. And both we are looking into the management on patients with dementia or elderly patients. And we have here doctor, Miss No Siti No Fazliza. Faliza, sorry. Okay,
It's
who's
okay.
from KPJ, and of course KPJ is sponsoring speakers on here. It's not sponsoring as in money or anything. They have provided speakers to educate us and the nurses, and most of the nurses watching in. We should appreciate the KPJ's effort. Okay, and this time, Siti is from KPJ Johor. And with her, she has a lot of support. Who is next to her? Your Chief Nursing Officer. Hi. Okay. So without further ado, let's start.
Okay. Nanti mana ni? Share slide.
Share your slides.
Okay. Wait.
Yeah, sure.
Can we start now?
Yes. Please start.
Okay. Okay. Assalamualaikum warahmatullahi wabarakatuh and very good evening to everyone. So, as you know, from time to time and recently, number of elderly patients who are admitted to the hospital is getting increasing. And have you ever encountered a situation where the elderly patient you see in the morning, maksudnya pernah tak macam anyone of you yang encounter situation pagi, we meet the patient in different condition and situation, but then at the evening he becomes someone else macam tu. Contoh, in the morning patients are very good, very cooperative, talkative, respond well to you, but then in the evening you find out that the patient is like someone else, jadi apa ni, agresif, jadi agresif, jadi someone yang irritable macam tu. Or maybe yesterday you meet the patient, he good respond to you, but then after a few days when you come to see the patient becomes someone who are like to sleep most of the time, becomes too poor and less respond to you. So in this situation, what is you normally respond to? Maksudnya apa selalunya all of you akan respond lah dengan situation macam ni. Pernah tak macam when you see this situation, mesti you akan kata this elderly mesti try untuk protest, tak dapat discharge ke, ataupun mesti you think of there is a certain pakcik ni entah dapat gangguan dalam bilik tu sampai dia jadi someone yang berbeza daripada apa yang he used to, macam tu. Ataupun pernah tak you terfikir startlah tu patient tu dah nak meracau, dah menyanyah, because they are elderly. Itu memang biasa untuk elderly, lagipun patient tu kan dementia. So these all of thing yang you pernah jumpa dekat ward ni, pernah tak terlintas dekat all of you yang apa sebenarnya yang berlaku kepada elderly ni? Okay, so apa yang saya nak cuba share hari ini adalah berkaitan dengan situasi ni lah. Okay, so sebelum kita pergi jauh, so saya kenalkan diri. Assalamualaikum warahmatullahi wabarakatuh. Okay, saya Siti Nurfaliza binti Muhammad Kasim. I'm staff nurse from KPJ Johor Specialist Hospital. Currently working in medical ward for almost 13 years. Walaupun Dr. Betty kata tadi nampak muda, tapi saya dah tua dah. Okay. Wasting anything.
Kita tengok. No, dia kena download lagi. Kita tak. Kita dah lupa.
Okay. Go on.
Kita belum.
So apa
Dia
yang saya
memang minta
nak malam
apa
ni?
Kejap ya, ada orang. Okay, go on.
Cantik dulu.
You please unmute yourself, yeah. Please unmute yourself. Okay. Sorry, there was some.
Okay.
Okay.
Okay, so apa yang saya nak share ni could be beneficial for you in care of patient elderly in ward, and also could be beneficial for you bila care of your parents lah. So hari ni I would like to share some of information regarding management of delirium in elderly from nursing perspective. Okay.
Okay.
For these next few minutes, so I will talk about definitions of delirium.
Yeah.
Definitions of delirium. What are the differences between delirium and dementia? Types of delirium, risk factor and the causes of delirium, diagnostic methods for delirium including the tools which is normally used to identify the delirium, management of delirium including the pharmacological and non-pharmacological treatments for the delirium, and complications of the delirium. Okay, apa sebenarnya delirium ni? Okay, what is the delirium actually?
Are you okay?
Um,
Your slide got problem? Okay.
so, delirium is an altered state of consciousness which is characterized by episodes of confusion that can develop over hours or day, which is normally is transient, reversible and fluctuating. Maksudnya delirium ni adalah perubahan daripada kita punya level of consciousness. Dia akan berlaku dalam tempoh masa yang sekejap lah, within an hour, a day macam tu. Sudden onset. Dia adalah something yang it's transient, reversible and fluctuating lah. Benda tu boleh berubah-ubah dan dapat di akan jadi on and off lah, bukannya all the time. So delirium is not only affecting your level of consciousness, but then delirium can affecting your memory, your thinking, your language, your behavior, your mood and also your personality. So delirium actually can be occur at any age, but most commonly occur is among elderly. So study has shown that at least 10% of the elderly who are admitted to the hospital they will experience delirium. So delirium actually is a geriatric emergency, which is very important as red alarm lah when we care of the elderly patient. If we are not treating this delirium or the causes that lead to delirium, it actually putting the patient at the high dangerous states lah, which is we can lead to declining of their health status and may cause a death to the elderly. So, what is the differences between delirium and dementia? Why we should know? Kenapa kita perlu tahu sebenarnya apa perbezaan antara delirium dengan dementia? Okay, because most of us kita itu dengan dementia. Tapi sebenarnya tak sama. When we assuming that delirium tu adalah sama dengan dementia, apa yang berlaku adalah we always leave the delirium there without treating it because we
Lagging, huh? Is it my computer or your computer? Are you okay? Anyone lagging, huh? We lost you there. Siti?
a year until we realize that the patient actually
Siti,
has
we lost you there.
dementia.
Can you repeat some of what you said? We lost you there. I lost you for a while. I think it's my computer, my line, it was not stable. Can you tell us what's the difference? I stopped, I heard you until where there is a difference between delirium and dementia, and we should not take delirium as part of the dementia. Oh, yeah.
Okay, correct.
Yeah.
So
My line is not stable. Oh, your line is not stable. I'm not sure whose line is not stable. Can you?
And maybe until we realize that the patients are having dementia. So delirium is something that cause it happen.
So I'm breaking. I'm sorry. Can everyone hear me? You're lagging. Siti? Very lagging. Siti?
For those who are having dementia. Okay, dementia is something that you can reverse it. You can treat by treating it.
Oh, very, very lagging. Your Siti? Siti? Sorry. Siti? Can you hear me?
Yes, I can hear you clearly.
Okay.
Yes, madam.
Yeah, thanks. Means that it's hers that is lagging, yeah? So, okay, the other thing is that our participant is almost 100, so we only allow 100 because my Zoom can only allow 100. Okay, I think she has left us. Okay, but I think the point that dementia and delirium should be separated. So when you see a dementia patient, you find that they may have delirium. And this is exactly, it may be acute, it may be sudden, especially in the ward when dementia patients, when they come into the ward and they find things that are unfamiliar. Okay, can somebody leave this and watch from the Facebook, please? Because City can't come in then, because we have 100 people already. Dr. Chan, can you please leave? Because you are a doctor. Okay, thank you very much. No, I need for City to come in. So I can't admit anyone else but City only. City is not here. So for example, when you have a patient who actually has dementia, they have higher chance of having delirium during their ward stay. And the reason is because when you have dementia and you get admitted, the surrounding that is unfamiliar for demented patients tend to disturb them even more. Yeah. And that is why they go into the state of delirium. Sometimes delirium, they can just be confused. For example, when you talk to them, they talk about old things that happen, or they think that you're somebody else. But sometimes they can become very aggressive or how you call that? Not responsive to your command, and then they can be actually wanting to come out from the bed, okay, fighting. That's why sometimes we find it difficult. We have to, tie them up, and it's very painful to see. We have a lot of patients waiting to come in, but I still can't see Siti.
We are still in progress to. Okay.
Who is talking?
I'm Noraini, beside Siti.
Oh, I see you are already in.
Yeah. Okay.
Okay, you are already in, but I can't see Siti. What's wrong? What's wrong? What's wrong? Raini? What's happening?
Yes. We have hold on. Give me 2 minutes.
Okay, who is I need to mute this. Okay, sorry. There seems to be some problem. Oh, Siti, can you come on to the what, even if you have I better not add anyone. Siti, Noraini, anyone? Oi, Noraini? Okay, the problem is this, because we need to.
Hi, doctor.
Oh yeah, can we? You still having problem? Okay, you're back. You're back. How do, okay, this is what's happening. We have never had this problem before. I don't hear you. I can't hear you. Okay, share screen. I'm going to stop recording. No, I don't need. Siti? Okay, good. Well done. Okay, are you on? Can you?
Doc, sorry, because we lost our connection.
Okay, fine. So,
Okay, so we stop where just now.
okay, fine. Good.
Okay, we continue from the types of delirium, right?
Okay. Go on.
Okay, so there is 3 types of delirium. The first one is hyperactive delirium, hypoactive delirium, and also mixed delirium. So for hyperactive delirium, the patient will become agitated, restless, aggressive, anxious, and the worst case that the patient will become hallucinated and become delusion. In hypoactive delirium, the patient will become inactive, drowsy, stupor, sleep most of the time. Comparing between hyperactive and hypoactive delirium, because hyperactive delirium is easily unrecognized, and we are it with something else like fatigue or depression. So for the third one is mixed. Mixed means patients will have both hyperactive and hypoactive delirium. It will switch from hyperactive and hypoactive delirium on and off. Okay. Okay. Now we move to risk factor for delirium. So study has shown that people who are aged more than 65 and male gender are at high risk for having delirium. Other than that, if the patient is already had a history of delirium, having chronic disorder, for example, like depression, for example, like dementia, so they are at high risk for getting delirium. It's like having multiple medical illness, having physical limitation. For example, patients are bedbound, having amputate their leg, moving around, dependent with the walking aid, for example, or elderly who are having hearing and visual impairment. Other than that, the elderly who are having poor nutritional status, sleep deprivations, and also alcohol and drug abuse. All these are putting the patient at the risk for having delirium lah. Okay. Other factors that can cause delirium are surgery, prolonged surgery, invasive procedure, sudden procedure, polypharmacy or prolonged use of anesthesia, unfamiliar environment, for example, patient who are sudden admitted to the ward or the critical care area lah, which is make the patient feel uncomfortable. Other than that, yang memang common adalah because of the elderly having physical restraint. There's a lot of catheter or tubing on patient body. All of this can lead to delirium.
Yeah. Hello.
Dok,
Okay. Go on. Is you're lagging again. Hello? Yeah, you were lagging.
yeah dok, sorry.
You were lagging again. We didn't hear you at all. Can you hear me?
Yes,
Okay.
you hear,
We can't hear you.
dok?
Yes?
Okay.
Are you talking? We can't hear you at
Yes,
all.
doktor dengar saya?
Boleh. Sekarang yes.
Okay, okay. Actually, there's a lot of mnemonic that can cause delirium lah. Tapi what I try to share here is this mnemonic pinch me is easy for us to start in our head when we dealing with the elderly, so that we can easily identify whether the patients are having delirium or not. So in pinch me mnemonic, first one is pain. Second one is infection for eye. N is nutrition. C is constipation. H for hydration, M for medication, and E for environment. So all these things are easily for you to identify whether what are the causes that can lead to delirium for your patient lah. So based on these causes, from this pinch me mnemonic, you can plan your nursing care to prevent it lah, to prevent the delirium. Okay, so when talk about diagnostic method for delirium, so when you see your patients are having changes in their behavior, in their action. So the first one, of course, you can observe whether your patient actually having or show you the signs of delirium. The second one is from your interview session between you and your patient, and also from you and the carer, the family members of the patient. The third one is from your physical examination. The fourth one is from case note or cases, and the last one is from the investigation. Okay, for example, if you see the patient started to agitated, start to become restless, and at that time you see that the patient is holding their abdomen area, for example. So from that you can maybe think that the patient may be in pain. So from that you can interview your patients or their carer and family members. Maybe from the interview session, you know that the patients are BNO, are not passing motion for more than 3 days. So, okay. So when you do the physical examination, you found that the patients are having abdominal distension or tender. So after that, you may see your cases lah from your intake and output charting, whether true or not your patients are not passing motion, for example. And from your medication chart, you also know that maybe the patients are on any or many painkiller, which is can lead to constipation. So from investigation, so maybe you can see whether there's elevated of the creatinine elevated of the urea. So from that, you actually can help the physician or consultant to see to identify what are the causes that may lead to delirium, for example. Okay. Okay. In identifying delirium among your patient, actually there are lots of tools that used out there to identify whether your patient really having delirium or not. But then these three I just pick up because ini adalah yang most common use. The first one is diagnostic statistic manuals of mental disorder DSM-5, confusion assessment CAM, and also for a test. But then compared to these three, for a test adalah yang paling simple, direct to the point, and easily can be used lah. So here is the example. So ni DSM-5, which is lagi subjective and can make you confused lah. So CAM, if I'm not mistaken, HKL using this one. Cam score this one. See, you can see here for 80 assessment ni it's direct because it's directly show the score and it's easy for you to assess the patient lah. So if the patient having score more than 4, it means that patients are possible to having delirium. Okay. Okay, when we talking about management of delirium, actually management of delirium ni dia lebih kepada we treating the underlying cause of delirium. So when treating the cause of delirium, it can be either from pharmacological treatments ataupun non-pharmacological treatment. For pharmacological treatment, normally the consultant, for example, they will use antipsychotic drug lah. So there is two types of antipsychotic drug. The first one is typical antipsychotic, and the second one is atypical antipsychotic. Typical antipsychotic which yang normally used is haloperidol, which is it's having minimal effects on vital sign, having minimal interaction with the other drug, and may cause, but then it may cause extra pyramidal symptom. For a typical antipsychotic, difference from typical antipsychotic is less risk for extrapyramidal, but then it's high risk for causing orthostatic hypotension. So what other drugs we normally use is olanzapine or Zyprexa, Seroquel or quetiapine, and risperidone. But then just be cautioned that Seroquel can putting the patient high risk for urinary retention and constipation. Risperidone can is good because it's having less sedative effect lah. So for non-pharmacological treatment actually lebih kepada how we plan the nursing care for the patient based on the causes that causing the patient to having delirium. So nursing care tu macam yang kita bilang, if the causes of the delirium tu from because of the pain, yes, kita just provide patient comfort, position patient to their comfortable position. If necessary to put something like pillow to just to make the patient comfort, giving medication regularly, even though just tablet Panadol, it can help the patient to experience less pain and provide comfort lah. If the patients having problem because of the nutrition, poor nutrition intake and hydration, so could be we just in our treatment putting some drip, assist patient in feeding, advice for home food cook, and of course we have to monitor their intake and intake lah. If the patient having delirium because of the urination and elimination problem, so that in our nursing care, of course we have to monitor lah intake and output patient, assist them to the toilet, provide comfort to the patient, and maybe we can provide commode or urinal to help the patient to pass urine, so that they will not retain tahan dia punya urination lah. So for sleep and comfort, maybe we can manage our nursing care so that we will not disturb patient punya sleep, time for sleep lah. And if the patient having any medication to help their sleep, maybe we can really plan the times that we can should given to the patient lah. Okay, for orientation and connection, in our nursing care, we should put keep on orientate the patient so that the patients are um, really oriented with the punya environment, so that they get used to the environment in the ward. For orientation, maybe we can place the patient next to the door, next to the window, so that they can know the times of on that day. Switch on the television so that they can give some idea what happened actually outside the hospital, for example. So for physical mobilization, if really that one is the main cause of the delirium, so maybe we can encourage early ambulation, suggest for physio, assist the patient to have moving around the room, for example. And if the vision and hearing is the problem, maybe we can advise the family members to bring the aids from the home lah, to assist the patient, to help the patient. So what are the complications of delirium? Why we have to prevent delirium? To prevent the complication. So complications of delirium, of course, if we are not treating the delirium, actually we can increase the functional and cognitive declining in the elderly. We can put the patient, increase the risk of complication like risk for fall, risk for injury, for example. By having delirium, actually we putting the patient untuk lebih lama stay in the hospital. Delirium also can cause increased risk for dementia, increased healthcare, can cause increase of burden to the carer, and the worst ones is can lead to death lah, can increase mortality rate. So what we should do if we find out that the patients are having signs and symptoms of delirium? Of course, the first one, we have to monitor, we have to inform our MO, medical officer, or our consultant in charge of the patient lah. So while we're waiting for the doctor to come, maybe at that time we can identify what actually happened to the patient, since when that the patients are having delirium, what are the possible factors that can contribute to delirium, or what are the causes of the delirium. So at this time you can automatic remind back the mnemonic that I explained just now lah, so that from that you can have some idea what are the possible causes of the delirium to your patient. Next, you have to monitor your patient closely lah, not only your vital sign but also your intake output and how the behavior of the patient. It may necessary for you to use the behavior chart to monitor your patient behavior lah. So if your patient's having delirium, it's good, and it's, if possible, to place your patient nearby your nurse's counter so that you can monitor your patient condition. It's good if you can advise your patient family members to be with the patient lah, to accompany the patient, not to provide the nursing care. Maybe they just maybe we can ask them to stay with the patient, to just monitor the behavior and the conditions of the patient, so that they can easily report to us lah. Next, we have to continuously treating the existing risk factor and the causative factor, which is can lead to another episodes of delirium. After that, we also can educate members and carers so that they have some idea what actually happened to the patient, so that they also can ask to monitor the patient punya condition, so that they can easily report to us lah. Okay, so when we talk about delirium, macam yang saya cakap tadi, kadang-kadang kita macam fikir yes, delirium when the patients are having behavior changes, it may due to other factors like macam unsur-unsur mistik ke apa, tapi as a medical team, as a medical person, we should think delirium when there is a behavior changes of the delirium first. By identifying, by suspecting the delirium, we actually helping the patient and also our doctor in treating the delirium. Because as I said before, delirium is something that we can prevent and we can treat it so that we can prevent it from getting worse and putting the patients at the dangerous condition lah. Any behavior changes, we should think of delirium first instead of other factors lah. Okay.
So that's your last slide.
Yeah.
Good. I think you're a good speaker, confident. Of course, can polish up a little bit, but unfortunately,
Sorry for the
that's
late
right.
in
It's
meeting.
okay. But you finished on time. Any questions any questions at all? Or do you prepare any questions?
Okay, question. Okay, okay, till now lah. Any question from the floor?
Any question from the floor? No. They just want to
Okay.
fill up the e-cert forms only. Okay, let me see.
Okay.
Can we give Xanax to the elderly? That is a good question. I
Yeah, betul.
myself, as a doctor, also sometimes I ask myself that question.
Okay,
What
this
is
is
your-
based on my experience, doc. What I know is, yes, Xanax, of course, can help the elderly to fall asleep. But then comparing Xanax with other medication, for example, still not, Xanax actually high toxicity to the patient lah, which is dia punya effect tu akan retain dalam badan pesakit tu lama, which is not good for the elderly lah compared to other medication, for example Stignox. So if our geriatricians, Dr. Peter pun, he will not advise to give Xanax cause dia punya effects Xanax to itself. Sometimes you give Xanax,
more long standing.
ya betul.
Oh.
Then Xanax tu sometimes kalau you bagi, the patient will become more restless, irritable and aggressive lah.
Sometimes Xanax, especially when a patient is not accustomed to the use of Xanax, then it can be quite long standing, and then sometimes they become drowsy for more than a day or so. Okay, somebody asked, can electrolyte imbalance cause delirium?
Can, of course.
Yes, which is a very, very good and valid reason. Always think of things that we can treat. For example, electrolyte imbalance is one. Okay, maybe bleeding, like Siti said, pain, abdominal distension. Okay, so all this may be treatable, and then may make the patient feel better, and then relieve them of the delirium. Okay. Any more questions? That's very good. How about urinary tract infection or dehydration? Well, Siti, what you think?
Okay, regarding the electrolyte imbalance, that is why when your patients, when the elderly patient admitted to the hospital, electrolyte tu dalam kita punya blood result, you have to really monitor their intake and output. Of course, dehydration can of course lead to delirium. Even though slight changes, a slight decreasing or increasing the number of the reading, for us maybe it's okay, but then for the elderly it can affecting their condition. So the baseline for the electrolyte is very important when the patient is admitted to the ward lah. Dehydrations, of course, dehydration can affect the electrolyte reading kan.
Yes.
So of course dia akan menyebabkan putting the patient high risk for getting delirium lah. The other question is urinary retention tadi tu, itu pun sama. Urinary retention, constipation, itu semua memang common problem yang selalunya affecting the patient and causing delirium.
Yeah, you must realize that we're dealing with patients who are very elderly with multiple problems, okay? Not just multiple medical problems. Sometimes they themselves have underlying dementia, then their mobility is also a problem. So all these have to be looked into. And when they get admitted, they could be in heart failure, they may be diabetic, they may be on multiple drugs, IV Lasix. So yes, very important to look at every aspect of the patient, yeah?
Okay. When you care of the patients who are elderly, you cannot point at one point saja. You have to assess from top to bottom lah. Semua kita punya element, as I said, nutrition, hydration, elimination. You have to go through one by one so that you won't miss any important aspect that may lead to delirium.
Okay, good. I have to go because we have another webinar at 9 o'clock. Do join us, Siti. We are talking about how to manage dementia, especially for GPs and all, but I'm sure the nurses can learn a few things. And we will also be giving out e-cert. Don't worry about the e-cert. I found a new intern and we're working on the backlogs now. Okay? So please give us some time. Don't email, don't message me every day asking me. Like today's webinar finish. Tomorrow morning I wake up and everybody asks me where's the e-cert. How am I going to give the e-cert? I'm conducting the webinar. I have no time. I finish at 10. Tomorrow morning you ask me to, and I have to full-time work some more. Okay, please be understanding. Okay, see you then, guys. Thanks, Siti.
Thank you,
You
Ada.
did a great job. Okay, I think you can be a very good teacher. Very
So I
proud.
can resign from now?
Oh, I got no job for you, so don't resign yet. Okay.
Okay, thank you, Ada.
Okay, bye-bye.